Let's go to the lobby. I'm going to let everybody in. Hello, everybody, and welcome to this discussion where we aim to discuss metformin and its use in managing antipsychotic-related weight gain. If people would like to introduce themselves in the chat, please do so you can maybe meet other people. By all means, share emails as well. And if anyone doesn't have the link to join the Mental Health Network, let me know and I will try and see if I can get a link from one of my other emails that we've sent out recently as well. So we've had 66 people sign up to attend this event, but inevitably people, life gets in the way. People have got clinics and everything else, so they might not turn up. So what I'm going to do is I'm just going to very briefly, we'll do an introduction of the people here who are facilitating the talks today, and then we're going to move the discussion over to yourself. So my name is Jo Howe, and I've recently finished working at Aston University, and I've spent the last nearly 4 years working with Professor Ian Maidment in the School of Pharmacy on projects related to the side effects of antipsychotic medication, and that includes weight gain. I'm still continuing that work, but now independently as an independent researcher. But still actually nothing feels like it's changed at all. I still communicate with Ian on a regular basis. I just don't think I'm being paid anymore. But anyway, I will move over. So Ita, would you like to introduce yourself?
Yes. Hi, everyone. My name's Ita. I am a pharmacist working in mental health here in the Republic of Ireland. I recently finished a PhD looking at managing antipsychotic induced weight gain using various different pharmacological adjuncts. So I've worked with Jo over the last few years on lots of projects, but I work part-time in clinical practice, part-time in research. And yeah, really looking forward to having hopefully an interesting discussion today. Thank you to everyone for joining and who joined us last time as well. We've brought forward a lot of the feedback. So really looking forward to discussing that today.
And Ed, if we go to you next, just because you're next on my screen.
Hi, everybody. I'm Ed Beveridge. Nice to be here. I'm a psychiatrist by background. I work as a clinical director for inpatient services in one of the North London mental health trusts. And I've had a long-standing interest in thinking about physical health in people with mental illness, particularly around what we refer to as the mortality gap for people with severe mental illness, but increasingly thinking about the much wider population of people with mental health difficulties and what we can do differently to reduce the likelihood of long-term conditions and early death. And I'm really pleased, Jo, to have been put in touch with you and your networks. I think it's great that you're doing all of this work and looking forward to the discussion today.
Brilliant, thank you. And then Claire?
Hi, my name's Dr. Claire Jones. I'm a psychiatry specialty trainee. I'm an ST5 in Southwest London. I'm one of the Royal College of Psychiatrists physical health scholars, and I work with Ed. And as Ed said, I support his work with hopefully reducing the mortality gap and aiming to improve physical health status in our patients. I've got a background a while ago in acute trusts and was sort of fairly appalled to see how things worked in psychiatry. So I've been really spurred on to get this work going, and I'm delighted to join Jo and Ed today. So thank you.
Thanks, everyone. So what I just like to do is just preface this with a little bit of an introduction for the people who haven't attended and don't know the background to this. But some of the work that we did at Aston, we had an in-person event in March this year. And one of the things that came out of that was an understanding of how to use metformin prophylactically. And that arose directly from a talk that Ita, you gave over Teams, because I think your PhD viva was imminently or something, I think the next day, or you were handing it in or something like that very, very soon afterwards. And one of the challenges, so I don't know, Kirsty Matthews on, because I was approached very quickly after Kirsty to try, after the event by Kirsty, I don't think she's in the call, to see if there were any guidance around using metformin prophylactically in respect to weight gained, thresholds, percentages, etc. And this was to try and work out within their local trust how they would do that. So I think this raised some wider questions over the prescribing of metformin the responsibility of metformin, and thinking wider than just secondary care, thinking about the interconnection then with primary care as well. And I know, Claire, that you had some insights that you had to offer based on your own experience of treating patients in clinic and prescribing metformin and trying to get that sorted with the GP. So I just wondered if you wanted to share those.
Yeah, I mean, so currently I'm working in an inpatient unit, but prior to that I was working in a IRH or CMHT, and I suppose this wasn't a one-off, this was a regular sort of occurrence, and I wonder if other people have had these issues. I'd see a patient, would be either starting them on an antipsychotic or increasing dose of antipsychotic, and would have noticed a weight gain, or the patient would have come to me complaining of a weight gain, had asked in my letter and discussed with the patient about starting metformin. Everyone seemed to be happy, patient, myself. You'd write to the GP, ask the GP to commence them on metformin, giving a bit of sort of reason why. See the patient a few months later, they'd come back, oh no, GP didn't want to prescribe the metformin because it's off license or it never got done. And the patient subsequently, over those several months, continued to increase in weight. And I suppose I'm expecting that is a fairly common pattern of occurrence that other people might have noticed. I suppose by setting out a bit in my letter as the rationale as to why metformin might be useful for this patient, I had sort of thought that the GPs might be on board. But equally, as Joe said, who is responsible for this? What can we do? Have other people come up with solutions? Have other people had this problem? And I suppose that's why we kind of thought this was a good sort of starting discussion point. So I'll sort of open up to the floor to see if anyone's got anything to add.
Yeah, I mean, I don't know, while we're waiting for people, so you can put in the chat, you can put your hands up, we can take this very, very smoothly. But I think there are a number of issues that I've had people coming to me in respect to, and I think, Ita, it's slightly different in Ireland because you have different, I'm not calling them permissions, is probably the only word I can think of, different structures, different systems. So it feels that you don't have the same implementation challenges. Kirsty's just joined, so in a bit we'll get Kirsty to let us know.
Yeah, I was just thinking about what Claire said there. In Ireland, we don't have the same, my understanding is from my pharmacy colleagues in the UK, these kind of shared care arrangements. And I was just thinking about what worked, because we probably started looking at trying to increase our prescribing rates of metformin around 2020, I think, at this stage, and have actually had a lot of success with it. GPs, we do run into some barriers in terms of the continuity of prescriptions, but it is the psychiatrists that are starting it. I think what has helped with that is that we did some work to create a national level guideline that addressed both metformin use and use of GLP-1 agonists. But even prior to that, in local settings, we did a lot of work in conjunction with our endocrinology colleagues to get them to come in to speak to psychiatrists to address, or psychiatrists to address, a lot of the misconceptions that exist around hypoglycemia, those kind of things. There were some bits around metformin causing renal dysfunction, or, really, I suppose, to promote it as a safe drug. I actually explicitly remember one of the endocrinologists coming in to say, metformin is the safest drug that I prescribe on a day-to-day basis in a lunchtime talk, and that actually really making a difference to our prescribing rates locally. I don't fully understand in terms of how the system works in the UK, but is it the case, Claire, that it can be started by psychiatric prescribers, or could it be started by you and then continued in a primary care setting? Or is it the case that the expectation is the management of physical health side effects occurs within primary care? How does that work?
I mean, I think if we want to, as psychiatrists, I think we could probably have written an FP10, an out of hospital prescription for metformin. Mm-hmm. But obviously that's normally just for 7 to 14 days. And then after that, it's up to the GP whether they kind of continue that prescription, really. Mm-hmm. Certainly, I know some of my colleagues did give an FP10 for metformin, and it just wasn't continued by the GP.
I guess we'd need GPs here, wouldn't we, to be able to feed back on that bit, and that's probably what we don't have. I mean, one of the things that
yes, GP if it helps.
Oh, yes, you do.
Oh, we do. There
Brilliant.
we go. Well, so before we say that, what I'm just going to say is ask people, can you put in the chat, do you have a good enough understanding about the evidence base for metformin, or would you like, and I'm going to put Ita on the spot, would you like Ita to very quickly just tell you what that is? So if you can just put in the chat, if you want that, let me know, and then we could do that. And then where's my GP gone? It's disappeared from my screen.
Judith, I think I can see her. Hi, Judith.
Right, okay.
Unmute and jump
over to you.
Hello. Yeah, I thought if I put my hand up, I might come on your screen. Yeah, so I'm a GP in East London. We have a very high level of diabetes in our area. So we prescribe metformin like Smarties. Honestly, I mean, there's barely a patient who isn't on it. And it's, I mean, we prescribe it for polycystic ovarian syndrome. So anybody who, any woman who is overweight and wants to get pregnant and she's got PCOS, we prescribe metformin. I've even got one patient who has a really, really rare telomere disease where there's some evidence, but very, very little, that metformin is helpful. I mean, it's such a safe drug. I will give it to pretty much anybody. It doesn't cause low blood sugar, so it's very safe in that respect. It doesn't cause kidney failure, but if you have kidney failure and it's very severe, you do have to be careful with it. But it's safe for your kidneys so long as your kidneys work all right in the first place. But yeah, I mean, so many people are on it. It's our first line drug for diabetes. It's our first line drug for sort of PCOS and trying to get the metabolic changes right for there. I mean, I'll prescribe it for anybody. It's more about, and it's cheap as chips, so it's really easy to prescribe, whereas sort of Manjaro you can't get hold of for love nor money. So this is the one thing that we might actually be able to do.
So could I ask Judith, because sometimes I wonder, like that it is used in pre-diabetes, diabetes, those sorts of things. Is it the case that, say, in Ireland, we have the Irish College of GPs, I'm assuming you have a national kind of oversight body. Do they have guidelines specific to managing PCOS or those sorts of things which endorse metformin use that we might be missing to support GPs in prescribing it more readily, or something? Do you think something like that would be useful, or is missing, or do you have any thoughts?
We tend to go with NICE guidelines rather than Royal College of GPs, and I'm not sure. I haven't looked for metformin for anything else, so I can't remember. But I don't think there's anything around. But that would just be for kind of PCOS, and of course, you wouldn't get any men included in that if you did that. So I think I read the Irish guidance, which had sort of using metformin for prevention of weight gain. If we had something like that, whether it's national and whether we could get NICE to do it, whether it's whether we did it locally and we could get our local clinicians to, our local prescribing committee to do it, then that would work. Yeah, if the Leicester tool kind of sort of said, yes, this is recommended, then that would be brilliant, wouldn't it? Any kind of national guidance would be really, really helpful, which I'm not aware of there being in the UK at the moment, or at least I haven't found it yet. Maybe we'll let Ed jump in there to save the day.
I don't know about that. I think Judith has already saved it on behalf of all GPs. I suppose I wanted to sort of flag up a couple of reflections of general principles which apply here, because there's clearly not we'll talk about it in a moment, but there's clearly not an evidence gap. It's not as though we're doing something for which there's no evidence. It's not as though it's particularly risky. It's certainly not as though it's expensive. And yet it seems the logistics of it, for whatever reason, are really hard to do. And I suppose there's a couple of things which we definitely know about mortality gap and long-term conditions in all sorts of illnesses, not just mental, which is that there's an implementation gap, which means that you have evidence, you have guidelines. There are billions of guidelines that tell you what to do in terms of preventing weight gain and treating the side effects of medication, but they don't get done. And I think we focus a lot on, are there guidelines, but we actually don't look at if there are guidelines, why aren't they getting implemented? And I think that for me is an area that's potentially more fruitful to think about, because I don't see why, Judith, at your local level you should be generating this guidance, because people in Tower Hamlets are not that different from people in other parts of the country or indeed the world. But the other thing is, I suppose in the UK and in the NHS in particular, we're still way too reactive and and not nearly proactive enough. And I know that we're talking a lot about prevention, but actually Claire's example is a really good one, because if you think about it, the point where you prescribe something for somebody that might cause weight gain is the point you need to do the thing. And actually, if 3 months pass and for whatever reason the person hasn't had metformin and then they put on all of that weight, it's much harder to shift. So I think there's probably a bit of a cultural thing around shifting to all of us as prescribers thinking about proactively what do we need to do to mitigate potential side effects. There's also something about our appetite for risk, because whilst we heard from you, Judith, that it's a very safe drug, loads of people take it, etc., psychiatrists might feel very risk averse and think, I don't really know what's going to happen if I prescribe this, because it's not something that we do frequently. So you're left with this sort of quite disparate set of views around whether and how we should do this. But I'll stop there. But there were just a few general reflections I had.
Before we move on too much, we have had a couple of people who have just asked for a quick summary of the evidence. So we know there isn't an evidence gap. So Ita, could you summarize this in a few sentences? And what I'm going to do is I'm going to put the link into the previous, I'm trying to find it, the previous video of the recording, so they can go and watch that and have a much more in-depth analysis. But what is the evidence for using metformin, both as proactively and as a treatment therapy?
Yeah, so it probably is better to put up, as you said, the YouTube to the last talk that we did that goes through it in detail. But essentially within that talk, we just looked at some of the mechanisms through which metformin actually directly targets some of those appetite centers in the brain, which are responsible for increasing appetite, because we know from the majority of the evidence that actually the bulk of weight gain from antipsychotics is caused through dysregulated appetite. And people will know that from their experience with regards to patients that kind of crave higher energy foods, larger portions of foods when they're on antipsychotics, in order to mitigate against, or in order to, I suppose, fill their appetite when they're on it. Exactly as Ed said, in terms of it can work to treat weight gain, but because it seems to actually cause a plateau in some of those mechanisms responsible for increased appetite, or directly kind of target those, it's actually much more effective when we use it a lot earlier. So whilst preventative trials are useful in terms of looking at it from a baseline, actually it can be quite helpful as an early intervention to actually, when that appetite increase happens, to try and essentially knock that out so that people aren't gaining that excessive amount of weight, or they have better control over their appetite. It seems that it doesn't do that as well when it's introduced after. You almost have this kind of setting of a new body weight set point, essentially, for people once they've been on antipsychotics for a long time. So introducing it a lot earlier is actually key to getting a lot of the clinical benefits out of metformin, and really is the way forward. And as everyone was saying, it's cheap, it's equitable access, those sorts of things, whereas GLP-1s are not. I hope that kind of makes sense. It's difficult to go into it without the supporting slides, but because, like Ed said, we're focusing on the kind of implementation issues, I don't want to take up too much time with that, but I would encourage you to have a look.
Yeah, because you've already done that. So the slides there, the evidence is there. It's all in the previous talk, so people can easily access that. So we've got someone with their hand up in. So I think I'm not sure if I've got you the right around, but Mario, is that your first name or your second name? I'm not sure.
Yeah, that's my first name. I joined about just after 10 past, so I was rushing around this morning. But yeah,
don't worry. Life gets in the way.
Yeah, exactly. I just wanted to pick up on a few points. One of the points is diet and exercise, which is connected to this. And I don't think, obviously, I've only just joined. Exercise and burning off certain amount of calories, especially with connected to medications. Especially antipsychotic. If somebody's eating 3,000-4,000 calories a day and they're taking metformin, they're not going to lose much weight. They're only going to lose a bit of weight, because according to the research, for the first, I think it's 12 to 15 months, it's between 7 to 10 kilograms you're going to put on in weight. which is round about 18 to 20 pounds or 21 pounds in weight, which is a lot of weight. It's so I'm looking at a multimodal approach really, where you want to be looking at people taking metformin with a medication and asking potentially, or having an app, do they exercise? Do they burn off certain calories associated with the foods they eat? Because if they're eating 4,000 calories a day, they're not going to lose much weight. So that's the point I wanted to put across.
So this strays into so this is more my specialist area. I'm not a pharmacist by background. I'm a chartered psychologist, and what I've spent for the last 4 years is researching the non-pharmacological interventions associated with antipsychotic weight gain. And what I can tell you is the evidence for this is really, really mixed. The people who have the best evidence for controlling antipsychotic weight gain are a current program over in Australia called Keeping the Body in Mind Study, and that is a multimodal intervention. But what the diet and exercise programs fail to really address is the complex underplay that is caused by the antipsychotic medications. So the biological changes that occur, the metabolic changes that occur, that fuel the hunger cravings that are associated with it. And it's not just, if it was as simple as more diet and more exercise, we would have had a solution to this already. And I think what we're trying to discuss here is whether metformin used prophylactically can help with preventing or mediating some of those disturbances that are occurred because of the antipsychotic medications. I think we've got two issues where we've got the prevention of antipsychotic related weight gain, and then we've got the management of subsequent antipsychotic related weight gain, and that they're different and they require different strategies. But I think one of the biggest challenges I think we have is trying to target the hunger cravings. So the hunger drive, if you like, is a biological driver. And I, as a psychologist, find it quite cruel to ask somebody to override a biological hunger driver with a psychological strategy. I think people need some help with that. But I think we also need to disentangle hunger and cravings. Cravings, you can crave something whilst not being hungry. The craving could be potentially satisfied with, or maybe mediated by, psychological strategies. But it's a very complex issue. And one of the things that our research has shown us is that people are very often not informed about the side effects of their medication. So they're completely unprepared for this increase in hunger. They're completely unprepared for the fact they're going to wake up in the night, absolutely starving, going to the fridge, eating, and then they feel ashamed. So the whole thing is a really complex issue. And I think what we're trying to look at here is, what can metformin do to help address some of that? It's one tool in this massive toolbox that we have of resources available to target the problem. But what our research has shown us is that preventatively, little if nothing actually happens. And I would love to be corrected on that. So what tends to happen is the weight is gained and then help is offered.
Yeah, I totally get what you're saying. And I think prescribing metformin from the start of people taking antipsychotics is a very sensible approach. And I'm just wondering why it's taken maybe 20, 30 years for us to get to this point where psychiatrists and prescribers never ever thought about the side effects and just gave out medication. So I'll leave it there.
So we've got two people in the chat. I think Richard might also have something very helpful to offer there, but I'm going to come to Kieran first. Kieran, I noticed that you've had some problems logging in. I'm guessing you've got a connection problem.
Yeah, sorry about that. I was I could log in, but I couldn't hear anything. But yeah, so I think that the third thing we need to consider is, why are these people prescribed antipsychotics in the first place? So it's not just when people are prescribed the antipsychotics, they have an underlying condition. So that will also impact on why they eat. So, it's not just they get the antipsychotics and that will impact on their diet. So they have the underlying severe mental illness, which will also impact on their eating. So that also has to be taken into account.
Absolutely.
So that's a third factor.
It absolutely does, because the effects of the mental illness do have an impact.
Exactly.
But what we also know is that when people are prescribed antipsychotics, that the increase in weight is significant and rapid. So we've got two elements of the weight gain. You've got the antipsychotic side effect, and then you've also got weight gain and obesity at complex. You've got,
Yeah.
for us, we've got the impact of the antipsychotic, but then we've also got overlaid on top of that the societal influences. You've got genetics, we've got the impact of serious mental illness, we've got food poverty. You know, we've got, it's a really complex overlay of issues that affect antipsychotic related weight gain. And what we're trying to focus on here, I think, is literally the bit that's attributable to the antipsychotics.
Yeah, I understand that, but what I'm saying is that, you know, we need to take all the other things into account as well. But really, what we need to be thinking about is doing some sort of placebo-controlled double-blind placebo-controlled trial to see if by prescribing metformin prior to putting somebody on the atypical antipsychotics will actually work. That's the only way we're actually going to answer the question.
I'd like to just offer that back to Ed. There's, you know, is that something that would be reasonable to consider? Because if someone needs an antipsychotic, would you try them with metformin first?
If you look at the new paper from the Lancet Commission, they're actually suggesting that if the person is taking olanzapine or clozapine, you should think about it as a prophylactic, or you should give it as a prophylactic. I suppose think about it and do it are actually quite disparate matters, aren't they? And it's one thing knowing that this is something you could do, i.e. other people probably do, but maybe not me, and actually thinking about how does this become a standard part of the offer. I mean, I think focusing on those two medicines is quite helpful because they are the worst offenders in terms of weight gain. But I suppose there's another general principle, which is around, are we getting it right first time? Are we actually making the best possible choices at the beginning of a period of treatment or a period of long-term illness? Are we really considering, you know, whether something like olanzapine is the best treatment? Now, it might be because it's really effective in the acute setting. So I look after mainly inpatient wards, and I'm very aware that we use olanzapine a lot because it's very effective for people who are acutely disturbed. However, that doesn't mean they should stay on it for their maintenance treatment. And I don't think we're necessarily very good at looking at going beyond the acute episode into the longer term maintenance, whether that's for a year or whether that's for longer. So I suppose there are lots of opportunities to think about starting adjunctive metformin straight away, or think about reviewing whether someone should be on a different medicine earlier on, and changing it if we can. Clozapine is a different case because if you need clozapine, you need clozapine. So I think there's a really compelling argument for using it as standard with clozapine. It's quite uncommon to do that, but that's an area that we could really think about in some of the Royal College work that I'm doing, which I can say a bit more about if it's of interest, but I'll stop there.
Peter, are you replying to this, or shall I let Richard come in with his comments?
I will jump in just before Richard, if that's okay. Just I suspect he's a lot of interesting stuff to add, more interesting than me, likely. But I just wanted to ask Ed one thing. And it's come up before in discussions, which I don't think you were at, so like maybe it's a good time to ask. Obviously, as you said, clozapine is different in the context of treatment-resistant schizophrenia, but is there any space, do you feel? I know some guidelines or position statements from Port, Harvard, those kind of things, have explicitly recommended against olanzapine in first episode psychosis. Is there a space, do you think, for the Royal College or similar body in the UK to make a position statement around using it as abundantly as we do? As you said, there's an absolute place for it. It's very effective for many people, but the reality is internationally we use it way more than we need to, and even we use low doses for sleep, for all these sorts of things, and low doses can cause metabolic side effects as well. So do you think there's a space for a position statement on that? Would that discourage prescribers from using it as readily, or has this come up as something before for you? What do you think?
So we've got a lot to say about clozapine, you know, but about olanzapine I think that's interesting. So there isn't a position as such, and you probably wouldn't want to limit people's options. But what I think we should do, and part of the work I'm doing, which includes a position statement on physical health, is talking about how you make your decision first time round, and thinking much more about prescribing something weight neutral, i.e. i.e. usually aripiprazole, but actually there are others as well.
Yeah.
But actually looking at your default as being something weight neutral and only using something that isn't, if there's a clear indication, and then having a framework for reviewing it. Because I think that would probably be more effective. You know, you have to think about the unintended consequences of telling people not to use a drug, for example, when it turns out to be the best thing for the person. But I think I would be really keen, and we will be sort of pushing the message that how you make that initial decision is a really key element of protecting people's health in the longer term.
Okay, that would be great, because what always comes up and what can be frustrating from a pharmacist's perspective is it's this discussion around like that olanzapine or aripiprazole. Then you get the aripiprazole doesn't work. I'm like, I know, but like it's not one or two. You know, when we're thinking about shared decision making, or how we actually support prescribers being more diverse in the antipsychotics that they are prescribing, and prescribing higher risk from a cardiometabolic perspective where it is indicated, but not doing it maybe as one size fits all-ish as we do at the moment. So that's interesting. I will stop talking now.
Sorry, I pressed mute. See, I was being very 2020 there. I pressed mute because my dog started barking. So Richard, I'm going to move over to you and introduce you. So you're an endocrinologist by background, is that right? Just want to explain that for everybody else on the chat.
Yeah, that's right. I'm Professor of Diabetes and Endocrinology in Southampton. Okay, so you've muted, so I guess I've got the floor. So it really fascinating discussion, and although I'm an endocrinologist, diabetologist, I've had a long-standing interest in the physical health issues relating to people with mental illness dating back over 20 years. And I completely agree with Mario that it'd be great if we could have a lifestyle intervention to help people either treat their obesity or prevent the development of weight gain. But we undertook the largest study, not only in the UK, but globally about 10 years ago, that actually showed that it was not as effective as in fact, it wasn't effective at all, but certainly not as effective as we thought. And then subsequent systematic reviews have actually suggested that lifestyle interventions are really not helpful in terms of treating antipsychotic-induced weight gain. So that's not to say that we should throw the baby out with the bathwater and not consider it, but we certainly need to have other interventions in order to try to address this issue. And I think there are two sides to the coin. So the first is, what do we do in order to prevent people from gaining weight in the first place when they start antipsychotics? And the second is what to do once they've developed overweight or obesity. And when we start to look at the evidence around metformin, most of the trials that have been done have actually been done in people who've had established weight gain rather than in the prevention arena. And there was a Cochrane review that was done a couple of years ago that basically suggested that in addition that metformin could reduce weight by on average around 4 kilograms in people taking antipsychotics. And I think that's a meaningful weight reduction. So when you start to look at the health benefits of losing weight, around a 5% weight gain, you start to get significant weight benefits, and 4 kilograms is around that. So certainly this looks to be a good treatment. It's an interesting treatment because it doesn't work in the general population as for weight reduction, although there is some evidence that it has a benefit in mitigating steroid-induced weight gain. There is actually much less evidence about using it in the situation of people with first episode psychosis or when antipsychotics are first being started, which is part of the reason why the NIHR have just funded the metric study, which Kath Patterson has posted into the chat, and I'm the co-chief investigator of this study. And the study is really designed to actually look to see whether metformin used at the diabetes doses and started within 4 weeks of the initiation of antipsychotics can actually prevent weight gain over the course of a year. And one of the other things we were wanting to actually look at in the study is how long we need to continue the treatment for. So, is it okay to use metformin for the first year when weight gain is likely to be the greatest or not, or whether we need to be starting to think about more long-term treatment with metformin. And similar to what Judith was saying, I use metformin all the time. I don't have any concerns about long-term use, but of course, if we can avoid using long-term drugs, then so much the better. So the study is actually currently in setup. We're hoping to start the randomized control trial in around 6-9 months time from now. And if there are people who are interested in taking part in that study as a censor, we'd be very grateful for your expressions of interest.
Well, there you go. That's an interesting thing for people to do if they're interested. So, Kirsty Matthews, you missed this at the beginning because you weren't here, but this discussion arose from the email that you sent me a number of months ago, which discussed you needed some evidence to be able to work out when and how you might use metformin in your clinic. Do you want to come on and just share the challenges? Because I think one of the things that we were discussing before we actually came on is Ed and the Royal College are interested in knowing about the barriers that people have to using this prophylactically. So if we can spend the last section of this discussion today discussing the challenges that people have had in using this, then that I think would be helpful. So Kirsty, are you still there? I can't see because so many people joined. I can't see.
I'm here. My camera's not on. I'm sorry. Yeah, sure. So I work in the early intervention in psychosis service. So thank you for those of you who earlier on recognised the challenges that our patients might have. We can't treat them like a normal population, with their struggles. They are often quite mentally unwell. So yes, we wanted to try to prevent weight gain because obviously we see it in our clients. I am actually really interested in lifestyle medicine, so the holistic approach really appeals to me, but I am recognizing that in a lot of my clients it's quite difficult for them to engage in various aspects of that at different points of time. With metformin, we want to put it into our pathway. So what we wanted to do was really try to establish exactly, can we give it preventatively? Is it in response to a certain weight gain, number of kilograms, for example, and what that threshold would be, just to try to put something together, really. So we just wanted to know a little bit more about the evidence out there. Obviously, the Leicester tool does actually mention metformin. It's kind of in the section about those at risk of diabetes rather than specifically under weight gain. But yeah, is that enough, Joe?
Yeah, so I'm just going to ask you a question on that. Kirsty, is that because you needed to provide some form of robust evidence to inform the decision making about how and when you could implement this at which stage? Is that
yeah, absolutely.
So
if we're going to do any guideline, obviously it should be evidence-based, right? Evidence-led. And the additional thing that is a challenge for us, I didn't mention, is our GPs are actually disengaging with us, we find at the moment, in many respects, and some of those are around monitoring our patients, but also prescribing for the consequences of our medications. So if we do a B12 folate, they won't even take on the B12 folate result and prescribe for that client with respect for that. So then metformin is also another stretch onto that. So actually to get some pathway together would be really ideal. And I love what Ita's done with being able to get sort of endocrinologists like yourself, Richard, on board with that, because actually I feel like that's a pathway that's not really available to our clients where we are in Kent and Medway.
Okay, so I'm going to hand over to Richard because you've got your hand up, and then Ed, if you've got anything to add after that, you can come on.
So, Kirsty, just a very quick comment about the Leicester tool. So I was one of the co-authors on that. The reason why metformin is written in this place where it is in terms of the prevention of type 2 diabetes rather than as a treatment for weight gain per se is that we were limited in terms of being able to write where metformin is currently licensed. So it's not licensed currently as a weight management drug, and therefore we couldn't endorse it in the Leicester as such. And I think that part of that reflects the state of the evidence at the moment, and the reason why we then need to really do the trials to make sure that we do have the evidence to perhaps go back to the MHRA and actually ask for a change in the license for it to be used in that point.
Yeah, thank you, Richard. And we would be really interested in partnering with you guys.
Well, we'd be delighted to have you as a centre. So I think you probably see from the chat that the contact details are there.
Yeah, I was trying to say the same thing, but again, mute. It's a bit of a busy thing outside at the moment, so my dogs keep periodically barking. I have no idea if anyone can hear it or not. But Ed, is there anything else you want to add to that? Because I know this is the kind of thing that you're particularly interested in knowing more about.
Thank you. And I have no dogs in the background, you're pleased to hear, that I'm aware of. So I suppose if you were thinking really ambitious, absolutely, you would be thinking about, can we influence the MHRA in changing the license for metformin and adding it as an indication. Not my expert area, although I can say we are doing some work around clozapine with the MHRA, and they are workable with, for sure. They, so I suspect that, I don't know at what point you think consensus has been reached, and maybe it's not quite yet, although it feels like the evidence is kind of fairly settled, but whether there needs to be more around the early intervention population so that there's enough about prophylaxis, who knows. But I think as a future aspiration, certainly exerting some influence, whether it's via the Royal College or whether it's via other Royal Colleges, or whether it's a sort of joint venture in thinking about approaching and saying, actually, we really think this might make a difference. I suppose just thinking about barriers, some of them are very logistical, very technical. So, for example, in England, GPs have very robust systems for repeat prescribing. Mental health trusts don't. So setting something up as mundane as a repeat prescription for any period of time is actually really difficult in a mental health organisation, much easier for a GP. However, GPs vary enormously in their approach, their view about what they can and can't be expected to prescribe, take over prescribing, etc. And I know that there's been some collective action from GPs in parts of England, which may reflect in some of the comments that were being made. But I suppose I'm increasingly of the view that it's commissioners and systems who need to fix this, not GPs or mental health organisations. Because actually, if you are an integrated care system, which is the way commissioning is set up in England, I again, just making that clear, because I realise we have 4 nations, not 1 in the UK. Integrated care systems should be the way that problems like, we can't get this drug needed for this person under this service who will be back home soon, prescribed. You sort of feel like actually that's where some of the problems get fixed. So, for example, you hear a lot of, we're not commissioned to provide this. Firstly, is that right? People don't always know necessarily, but also actually then ask the commissioners to find a way of making it much easier, so that there aren't these barriers about who's paying for it, where's the governance. And I think a lot of people maybe started on antipsychotics in secondary care settings, inpatient or community, but most people with SMI who are on maintenance prescriptions are looked after only by GPs. And I think one gap in our pathways in general is that people don't have routine access to highly specialized medication review, which they kind of should. Even if you're on a stable olanzapine prescription, you should be seeing a specialist regularly to see if you still need it, you still need that dose, you need any adjuncts or alternatives. And I think something that we'll be recommending, our position statement, will be making sure that people have at least annual access to a specialist medication review and optimization process, rather than something that just looks at prescriptions and confirms that they're good to continue. But yeah, those are a few of my thoughts. I'll stop there.
Oh, Joe, you're muted, but
I'll
go quickly next.
I've got rid of the dogs, so hopefully that means it's going to be a little bit easier.
Won't ask how.
All I was going to add is that from what Ed said about it's sort of very much a systems and integrated approach, government approach. I think this is a really good document. Sorry if people can't open it, but as Joe just said, if you just search the title, this weight management for mental health, which has been done with the Welsh government and the Welsh Royal College, it is very much a framework approach that can, and perhaps we should be pushing for this to be in the other nations of the UK more and more. But I think the Welsh side of things have kind of got their ducks in order a bit more than we have regarding this. And so it's definitely worth a read, because it's a very well written document that covers a lot of the points we've kind of discussed today.
It's a really interesting one, actually. Just to follow up on that, Claire, because so Wales is a really interesting sort of case study, in a sense that the Royal College of Psychiatrists there has a lot of influence on the Senedd, the Welsh Parliament, and the Welsh government have got some really robust strategy around mental health and population health. Lots of challenges around implementation because of resource issues. You know, they really struggle with a lot of quite basic resources, you know, but actually in terms of their intent and their policy and the link between their politics and their parliament and their policy as concerns mental health, it's really quite impressive. So that's one of 4 documents that they've done. Another one on substance use, another one in the works on exercise specifically, so not generally lifestyle interventions, but exercise specifically, and they've already done one on smoking as well. So I found that really impressive, and thought, could you replicate that with the UK Parliament, which is a question for another day.
All I was going to say, Ed, was we've inputted into that document as it was going on. So we saw various iterations as it was being, we were consulted to be able to offer our expert advice based on the work that we'd done. And I find it quite interesting that it did have this holistic approach to it. So it wasn't just a one size fits all, element, or just looking at one element, because it does need a holistic toolbox to be able to look at this. So Kirsty, before we move on, has that helped you? Do you think you're any further forward, or are you still stuck with the same challenge that you had? I think it was back in May, June, when you first messaged.
Gosh, yeah, it was ages ago. No, it is helpful, and obviously I've got all of Ita's papers and other stuff that I've got since then, been collating during this time. So yeah, I think we're planning to put it in anyway, but yeah, it's about getting it in a timely way, I guess. That's my biggest challenge right now, preventative rather than,
yeah. So what we're trying to work out here is, what are people's barriers to using this preventatively? So if anyone wants to just add in the chat, if you've got the same sort of barriers, just add in as a thing, and we can collate that afterwards. And then I think Claire's also rightly suggested a little bit earlier is, has anyone overcome these barriers, and how, and what did you do that? Because that can also help the people who are facing the barriers do that. So Amario, we've got you next.
Yeah, I was talking earlier, and I meant to obviously articulate a holistic approach. That's what a multimodal idea is. It is a holistic approach, and having a person-centered, looking at people individually and holistically, is part of bringing down barriers. You know, that is the way forward. You know, and looking at what the individual wants to work on. You know, especially with prescribing and metformin with their medication. So having that whole approach is the way forward for me to
probably be very interested in something that we're currently developing. So I've been working with a psychologist from Weight Management Service, some dietitians, OTs and physical activity coordinators to develop a holistic tool to help people work out. So the tool would be given to people as they're prescribed medication for the first time, to help them to, 1, explain what the medication may do as a side effect, and then 2, the idea of the tool then is to help them work out which areas they would like to prioritize to work on to maybe help with. But obviously the whole document will help them work out, you know, in relation to their hunger, their food cravings, etc. And we're probably going to be looking for pilot sites later this year. So if you're interested, get in touch.
Absolutely.
And we're still developing it. We're currently working with graphic designers to be able to make it into a nice looking booklet, but that it would go out and hopefully be embedded within the choice of medication website, which would make it easier for people to download it. So if you're interested, get in touch, because it's something we can look at, and you can even just input into it as a stakeholder group if you're interested. But it would be very much coming at this. It's less focused on pharmacological adjuncts and more around the rest of the toolbox, if that makes sense.
Yeah, it does. It does. It makes a lot of sense. And you could always have in the future an application, an app, a phone app.
Yes.
As well.
Yeah. We just want to get the
it...
nuts and bolts tested first to see whether anything needs to be rejigged, once it's actually clinically administered. Because at the moment it's just being developed through lived experience and these core groups. So yeah, but get in touch and we can have I can share with you where we're at the moment with it.
Thank you very much.
Thanks. I guess I was just thinking about whether in terms of ways to overcome these barriers. And I guess another way of looking at this is to sort of flip it a bit and think about, say, in your system. So say you're in an ICB area, as we call them. So a big part of a chunk of population, which is one set of commissioners looking after it. Could things like obesity or weight management strategy or population health strategy that touches on prevention of obesity actually be somewhere where you could, a lever that you could use to support various different kinds of intervention, including things like adjunctive prescribing for people with first episode psychosis, because that's a group in your population who you could definitely identify as being at risk of obesity. There are some interventions which work. The licensing issue is a little bit sticky, but you could certainly say, please consider rather than mandating it, for example. But I sort of feel like one of the problems that we've had around solving the mortality gap problem in general is that everything is very, very piecemeal. So you've got mental health trusts doing the stuff that they do, you've got GPs doing the stuff that they do, you've got secondary other medical specialties doing what they do, and for patients there just isn't a sort of clear pathway through a lot of the time. But actually sort of thinking about what's the pathway for somebody who is going to develop a mental illness, is going to develop obesity, is going to develop complications and may die early, and where are the points that you can intervene on that pathway, and where's the strategy that might support that. And I think certainly in our position statement that we're working on at the moment, we're very much advocating an approach that looks at that sort of life cycle or pathway and thinking about what do you do right at the start of life, what do you do right at the start of illness, what do you do right at the start of a long-term condition developing, and what do you do to learn from all of the outcomes that go along the way. So I think I would also wonder about whether influencing the strategy around obesity and weight management, or type 2 diabetes, or all of the above in your area, and saying what's in there for people with severe mental illness on antipsychotics. Can we look at what you're expecting people to do across the piece?
Yeah, I think it's really important. One of the things that just popped into my mind when we were talking there is we're going to partner with MPFT, so the Midlands Partnership Foundation Trust, for some Midlands focused work. And in secondary care, because of the issues they've got around shared care agreements with GPs, they are taking responsibility for their patients for 12 months and then transferring care back to primary care, but they're still having issues with that. So if you are going to do that, and then it would make sense to potentially trial metformin prophylactically within the secondary care organisation for that period, for that group of patients who are under that. Obviously not every patient is under the care of secondary care. So I suppose I'm formulating this question as I go, which is why my brain's a bit slow. What would we need in place to allow people to then more introduce metformin earlier? Is there enough early follow-up? We've only got 5 minutes left, it's just told me. So are there enough touch points early enough on to see the weight being gained? Do we need a better understanding about how often people are followed up in secondary care from initial prescription? I'm just putting that out there for questions. Ita, I'm going over to you because you got your hand up, and then we'll go back to Mario.
Oh, well, I wasn't going to touch on that point. I had a separate point. So I don't know. Do you want
No,
people to
that's fine.
answer
I've
that
just put that out there
first?
for people to think about.
Luckily, just thinking about practice in Ireland, I mean, you see that frontal central weight gain in people very early. I think the problem is still the actual generation of the prescription rather than there not being enough points of contact, because even when people do go in, if it's at a 3-monthly instead of getting the weekly, 6-weekly weights, they're still not getting the prescription. So I think that's more the problem. What I was going to say, and it's just thinking about again, these implementation barriers, because I'm just conscious of the fact that we do spend so much time talking about how we actually can increase the prescription rates. I was thinking about, and I'm thinking on my feet, so this is not going to be very articulate, but thinking about what worked in the context of when GLP-1 agonists were first introduced for weight management in the general, for obesity management, or for people living with obesity more generally. And before they were licensed, say when you had the Victozas or the Ozempics, which were licensed for diabetes management, and we had a lot of resistance in Ireland, and I imagine it's the same case, although I believe the UK might be a little bit more risk averse because of kind of structured arrangements that you guys have. What worked to actually get people to prescribe those medicines? And I think from going to a lot of obesity conferences around that time, was actually the patient voice. A lot of the time there was a lot of advocacy from people living with obesity, a lot of input into national level strategies, a lot of education around what obesity is. Like there was a big national network of work done, I think, here, and that actually changed a lot of our prescribing practices. You had people living with obesity coming out saying, we expect access to pharmacological treatments, etc., etc. I don't know if what I'm saying is making any sense, but I'm wondering, is the voice of people with SMI missing sometimes? Because the mortality gap, we've known about it for however long. But like, what is it? Is there something there that we're missing? Or if anyone has any thoughts on that, I don't know if I've made any sense at all.
So I think obviously you know my personal opinion about the voice of the lived experience in the research literature. It's one of the things that shocked me the most when I came across to mental health, is how poorly represented people with SMI are, and how appalled I am to look and say, I read a research paper and it's a psychiatrist telling me what they think service users or carers think about a particular situation in their life, as opposed to the actual lived experience voice. That I think is sorely lacking, and I think that's us as researchers as well. We have a responsibility to bear on that, and the lived experience should be front and center in all of our research. But that's just me on my little soapbox. Ed, I think you were going to say something back to Ita about that as well.
No, just that voice is always missing, and it's partly because if you have an SMI, it's harder to have a voice that gets heard against the sorts of news stories you see about people with SMI. Carers definitely have a voice and definitely have views and definitely want to be more involved. So maybe that's the other route we could think about for advocacy, because carers advocate brilliantly and they're always talking about weight gain.
Yeah. One of the other things I find very helpful is to get the voice via the national charities, because that can help coordinate that voice and it can help come at it. You have a stronger positioning then. So I think that can also be a useful way. And again, that's something else that we could look to try and do as well. So Mario, back to you. I feel like it's a discussion with like 6 of us, but hopefully other people are benefiting from said discussion.
Yeah, I was just thinking about, because I've just finished at uni, I've just finished my degree in psychology and counselling, and we were covering a module on health psychology about health literacy. I think health psychs are fantastic on research projects. I think they can go out there, rather than delivering a leaflet, they can explain to patients, they can get that lived experience from patients. And I'm currently on about, I think, 11 or 12 lived experience advisory panels across the country. And I know when health psychs are involved, I think they're really, really not just important, but they can really like get that message out really, really well to patients and stuff, and ask exactly what their preferences are, patients' preferences, which is really, really important. So I just wanted to put that out there, and I know we've hit 1 o'clock now, so yeah.
Yeah, we have. Yeah. So I'm aware that people have clinics to go to. I'm happy to stay on this call for another 5 to 10 minutes to finish up if anyone's got any burning questions or suggestions or areas for follow-up, etc., etc. So please do to stay on, and I can waffle all you like while you all start to disappear. But we have had quite a few people turn up today. We didn't expect as many people for a discussion, so thank you very much to those who have turned up, and please take over any remaining discussions, concerns, whatever you want, over to the mental health JISC mail to continue, because that's one way in which we can continue with all of this. Claire.
Just a slight plug. Myself and Ed, along with a colleague called Toby Pillinger, have just done a podcast for the Royal College of Psychiatrists looking at physical health, and some of the things that we've discussed are on that. So I'll put the link for that in the chat, if that's okay with you, Jo.
Can you email the GISC mail as well, Claire, for everyone who wasn't here today? That's probably a wider representation because we've got significantly more people in that group than we have here. So that would be great.
Great plug there. Congratulations.
Yeah, absolutely. Yeah. And if you send it to me as well, I will put it out through LinkedIn as well. So so I think the more that we can do, the more that we can link to whatever exists, the more we can have these conversations, the greater the chances that that things will, the narrative will start to change.
Great.
But I was interested in your comment, Judith. And I've lost it because there's been so many in the chat since then, about the GP advocate. And I just wonder if that is part of the challenge. Do we need almost like a position statement, Ed, but from the key voices across the relevant specialties? So for the likes of Richard Holt from endocrinology, maybe someone from a charity like the McPinn Foundation from your lived experience, somebody in your GP, David Shires as your carer GP. Do you need something that comes out from these key people who are working in this area so that they can speak to their own clinical groups? Because we still work in silos.
And the question is, do you do that about a small thing like metformin? It's not a small thing when it works, but do you do that about a specific issue, or do you do that about the wider issue? Because the first is easier than the second, but actually the more ambitious one is the second. But I think it's working with other Royal Colleges is something we're really keen to do, actually. So I sort of, and we do have some contact with RCGP around our clozapine work. So I sort of feel like that's something that could happen with the right, with a fair wind, as it were.
Yeah. And I also think there's no harm in doing both, because you can start off with something small around metformin, but it feeds into a bigger strategy around the more holistic provision that we're talking about. But I think what comes up time and time again, and one of the things that I think I've worked out crucially from the research that we've done, is even if we did have a lifestyle and dietary education holistic intervention that worked, we actually do not have a service structure to insert that in to allow it to be implemented. So there's a number of challenges, and a lot of them do come down to implementation, and it's how do we make these work?
Neighborhood is the answer. Actually, it potentially is. It's just neighborhood is the answer to lots of things in our discourse at the moment. But I actually do feel like neighborhood could really deliver on things like this.
So Amario, we've got one last thing, and then I think we've still got a few people hanging on. So if anyone's got anything they want to say, please do so. Or perhaps they're just here to hear me waffle.
I wrote an article on eco walking, which is good for stress and good for health. So maybe I can put it up. So
put it in. If you're in the GISC mail, put it in the GISC mail, because what we want the GISC mail to be is to be a place for people to share the resources that they have to help learning, and also for people to have conversations and ask these discussions. I want to do this. Has anybody done this? Because there are lots of people all over the country trying to reinvent the wheel. The GISC mail has been created as a multidisciplinary or a cross-disciplinary network, and the idea then is that you can share that learning across a broader scale than you could say within your own clinical network. So yeah, absolutely, use it. Let's start and have some discussions. Let's start and see if we can generate them, and hopefully it'll give Ita and I some pointers for things that we can get talks on for next year as well.
Okay, I'll put it in. Thank you.
So we've still got a few people hanging on. You never know at the end, whether people are here or whether they've walked away and